improvement, and we're going to go ahead and get started this afternoon and turn out because of Joint Commission. So good luck to all of you who are involved in that. And just wanted to highlight from the announcement slides that registration is still open for the Lean Healthcare Academic Conference at Stanford, September 10th and 11th. And there are also a number of workshops the morning of the 12th. So we'll put a link in the chat during this talk. But we are very, very honored to have today Elaine Mead, who is joining us from Scotland, where it is now 8:02 p.m. So thank you, Elaine, for talking with us this evening. I'm going to briefly introduce Elaine. You all have her bio in the flyer for this talk, but she's extremely accomplished. She is what we call a friend of the Stanford Medicine Center for Improvement, and she spoke and gave a really powerful talk at our Lean conference last year, and this is going to be a continuation of that talk. But to tell you a little bit more about Elaine, she's the Executive Director of Improvement, Care and Compassion, an organization committed to supporting leaders on their improvement journey across the UK and Europe. She has 35 years of experience working in clinical, managerial, and executive roles within the National Health Service across the UK. She was the chief executive of the National Health Service Highland for 8 years. She originally moved to the Highlands of Scotland as their first chief operating officer. Elaine has been increasingly concerned about the impact of healthcare on climate change, population health, and pollution, and combines these interests as a PhD candidate at the University College Dublin, researching the potential interface between quality improvement and sustainable healthcare. I also wanted to mention that Elaine coaches and supports teams at the board and executive level on their quality management systems, leading for improvement and sustainability as leadership faculty for the Institute of Health Improvement and executive sensei for the National Health Service Improvement Vital Signs program in England. She's a founding member of the Catalysis European CEO Forum and continues to connect colleagues across Europe as lead faculty, facilitating and supporting the Forum Gamba visits from her base in Scotland. And finally, she was awarded a fellowship by the International Society for Quality in Healthcare and is a member of Q Scotland, the Institute of Environmental Management and Assessment, and the Royal Society of Arts, Manufacturers, and Commerce. So that is quite the resume. And again, Elaine, we are so privileged and honored to hear from you today. And with that, I will turn the podium or the virtual podium over to you.
Thank you so much. And that's so kind of you to give me such a lovely welcome. Let me just get these slides going from the beginning, and I hope you can see those there nice and clear. So thank you. And thank you so much for inviting me to speak today. As Lisa said, I have the absolute privilege of joining you this evening from the beautiful Highlands of Scotland, and I hope a number of you have been and visited us. This is one of the last wildernesses in the UK where you can walk for days and see absolutely no one. It gives you, for me anyway, a perspective and makes you feel sometimes rather insignificant. Today, I'm planning to share with you my journey into an understanding of sustainability in healthcare as a clinician, as an academic, and simply a fellow creature sharing the planet. So, sustainability means different things to different people. And up until fairly recently, it just meant maintaining the status quo. But here's maybe a more thoughtful perspective from the Brundtland Commission from a few years ago. And for us in healthcare, I want us to consider tonight, are we just meeting the needs of the present without actually considering the future? So here's the theoretic model that you may be already familiar with, the model of sustainability. And sustainability is held up then by these three pillars of equal importance: the social equity, environmental protection, as well as economic viability. And those three things have to and should be in balance. But of course, I know that in healthcare, currently the focus for many health services across Europe and North America is really mainly on the delivery and access, as well as affordability and efficiency of care, with honestly little attention being given to the environment as we struggle with the day-to-day pressures. Although, to be fair, there really is an increasing awareness of the waste in the systems. As you all know, that waste is estimated at more than 30% in modern healthcare systems, and we're becoming more expert at taking measures to remove that waste using quality improvement. So, of course, we do try to look at social equity, equity of access, support for patients with particular needs. But what about the bigger picture? This work here by Deva Nayagam shows that the countries of the global north, and for this definition, we do include Australia as it happens, but they represent 14% of the world's population. And together we're responsible for 92% of the historical carbon dioxide emissions, in excess of the safe planetary boundary. So it's clear that as the planet gets hotter, those populations that are least responsible are suffering more. And those greenhouse gases are making it hotter, much hotter. These climate stripes were developed by Professor Ed Hawkins from the University of Reading back in 2018. And you may have seen them in various guises and merchandise around the place. And they show for me clearly and vividly how global average temperatures have risen over nearly the last 2 centuries, actually since the start of the Industrial Revolution. And Ed, this year, has said he's run out of dark red. So I know as improvers, you like to see data over time, but honestly, this isn't really a chart that we want to see, but it's happening. The change of temperature and impact on our global weather systems is impacting around the world. Truly, it's taking lives and costing money. But I don't need to tell you that, of course, in Stanford, California. So here's just a graphic that describes that since 1980, there have been 46 confirmed weather or climate disasters affecting your state, with losses exceeding 1 billion each, including 14 droughts, 6 flooding events, 3 freeze events, 4 severe storm events, and 19 wildfires. But you will have already realized looking at this that this graphic doesn't even include the devastating wildfires in Southern California earlier this year, with the LA Times reporting an estimated $250 billion costs in damage and economic loss. Our hearts went out to you as we all watched this with horror. But we did know about many of the impacts of climate change on human health, and here are just some of them described. But it was, I guess for many of us, it was generally something that was happening somewhere else. But all of that's changed now. This is now much, much closer to home. It's not something that's going to happen. This is something that's happening now. Heatwave, storms and flooding have also, for us, resulted in the loss of life right across Europe. And we thought that we'd always be there, of course, as healthcare providers to help the people that come to harm. But not if, like in Pakistan in 2022, after the floods that left almost 1,700 people dead, we found that 2,000 hospitals and healthcare centres were damaged and destroyed. nearly 10% of Pakistan's healthcare capacity gone. Imagine. So healthcare's footprint, climate footprint, is estimated to be around 4.4 to 5.2% of the global total, meaning that if it were a country, it would be the 5th largest emitter of carbon on the planet. Now, interesting for me, and I didn't know this, that aviation, by comparison, is estimated to contribute between 2 to 5%. And not surprisingly, the more advanced the health system, the size of the country, the commitment to GDP, the bigger the impact. So what are some of our leaders doing? I've got here some documents from Scotland and from England, and nearly every developed country is now recognising the impact of healthcare on the environment. In fact, in NHS England, they were the first to actually make a commitment to net zero and then went further. They brought that into law under the Health and Care Act of 2022, reinforcing that commitment, placing new duties on leaders in NHS Trust to consider statutory emissions and environmental targets in their decisions, and they hold them to account for that. So let's just talk about what these emissions are and where they come from. They come from different activities in healthcare, and this is from the net zero document for the NHS. On the left here, scope 1 is from the actual things we directly control, like our services, our facilities, and local transport. Scope 2 then is from the electricity that has to be created for us to use to keep those services going. But something I simply didn't understand, either as a chief executive or a clinician, was the huge impact of what's described here in blue as the scope 3 activities. The things often that other people do and make for us to service our healthcare business. It's actually all of this stuff. Now, I hadn't given it a thought. If we need the drugs, we get them. If we have to have the consumables to deliver the care or to feed the machines, whatever we need, we procure it. If we're desperate for a new building, I guess we fight for one. Did I ever give a thought to how things were made or where they came from or what happened to them? Honestly, not really. Remember, of course, in healthcare, we're busy saving lives. And we're leaving that climate stuff to all those scientists out there. Or that was my thought, I'm afraid. But I did suddenly begin to realise that actually we were part of the problem, and that as a result, we had a responsibility. And if I didn't know that 71% of our carbon footprint came from medicines, medical equipment, and how things came to us, then I suspected, honestly, that others didn't know either. Here, my friend Bhagavi Sampath from IHI has translated these scopes into domains for us to think about our sustainability efforts. The built environment that addresses scope 1 and 2. But more interesting, maybe for me as a researcher, the care delivery and supply chain, which addresses the tricky scope 3 emissions that I was just describing. So as leaders in healthcare improvement, I would say that we now need to turn our skills and attention to doing something positive, something we do already quite well, using improvement to contribute to reducing the impact of healthcare on the planet. This excellent paper by Francis Mortimer from the Centre for Sustainable Healthcare in the UK describes the 4 principles of sustainable healthcare: prevention, self-care, lean service delivery, and low carbon alternatives. This addresses both mitigation and adaptation for the future. So all this knowledge then has sent me on a journey of further discovery. And I'm currently considering if we might be able to include environmental sustainability into our lean intervention as part of my PhD, as Lisa described. So in this context, lean to green, my language, is looking at the integration of our lean principles, efficiency, waste reduction, process improvement, with green sustainability goals, that environmental responsibility and resource conservation. And we're moving then in this work from operational improvements to something that intentionally considers environmental impacts. So we're all very familiar with this intervention, engaging teams of frontline staff using tools and techniques to remove non-value added waste as part of a robust quality management system. But what we might not be quite so familiar with is the fact that other teams, often in estates or facility departments, use slightly different approaches to remove waste from support services and functions. Food waste and physical bags of waste, for example. I'm almost ashamed to admit to you today that when I was in a position to have been able to influence things, I had a fantastic lean team shown on the left here, a KPO with thousands of trained improvers. And I also had an amazing green team. They were busy looking at how to remove environmental waste, working in estates. And I never, ever got them to speak to each other. Really, never thought about it. One team was intimately linked to the clinical process, and the other team hidden behind the scenes, doing their own thing. And on top of those groups, I had procurement people who were spending our money on all the stuff we use, doing that quite by themselves. So it got me thinking. We know that our improvement methodology delivers improvements in the quality, the experience, the productivity and outcomes of care. We know that. And we also know that an understanding and awareness of the whole process is critical. So how might we now then be able to secure the engagement and influence of staff and clinicians when they understand this bigger picture? Would they be able to look at their processes through a green lens? Climate change means that we simply don't have time, honestly, to develop a new process, and this can't be something else on top of what we're doing. So could we adapt our current approaches as a vehicle for looking at environmental protection in healthcare? The consequences of delivering healthcare are absolutely all around us. It's not just the stuff, it's how it's made, how it gets here, how we get rid of it, and all of that contributes at all levels to the triple planetary crisis. We are so busy, we don't even realize that the impact that we have isn't just on the climate, but it also contributes to pollution. And it impacts on nature, providing the things that we think we need, or maybe we do need, and we end up just having to throw away. So it's important not to just get driven to look at carbon emissions. Our waste, as I hope I've described to you already, is much, much more than that. And we have to be careful to look in the round about sustainability and how we might contribute and how we might manage that. But on my journey, there were two things I want to share with you today that really shocked me. And I've been in the business a long time, and I simply didn't know them, even after all these years. The first one was this one. It was the impact of drugs on our water sources and the ocean. The fact that these active pharmaceuticals were excreted. And I knew that, really, but I think maybe naively, I thought that all of those water treatment plants sorted it all out. I honestly did. But no, clearly not. But did the pharmaceutical industry ever help us understand this? Should we have realized ourselves that those are necessary? Sometimes drugs were causing harm in other ways, maybe how it was made or how it was transported, and then what happens to it after we've taken it. Practicing what in Scotland we describe as realistic medicine, shown in this report's come out just in the last month, it encourages us to only prescribe what is really necessary. I wish I'd realised this earlier. And then my second thing, what about all those plastics in those medical devices? I recognise we cannot live in healthcare without plastic. I understand that. But I had no idea until relatively recently that chemicals of concern leach out of these products, even giving sets and fluid bags. And they can have a really detrimental impact on human health. The plasticizers that make these things flexible are the very things that are the big problem. So that got me anxious, if I'm honest, and starting to look at my own practice. And I realized that these, what they describe as phthalates, might not be so much of a problem if you're a big, healthy person. But hey, maybe if you're a patient on a 3 times a week weekly dialysis, or a neonate at its most precious time, surrounded by plastic, when its brain's developing, that may be a bit of a problem. And a number of even senior neonatologists had no idea about this issue until, again, fairly recently. And it's now, and for me only now, do I understand why nasogastric tubes get brittle over time. So, as clinicians and improvers, I put to you that maybe we need a new type of leadership in healthcare, as we and our staff are trusted ambassadors of messages. And this is just another message. There seem to be a couple of type of leaders that are emerging that we could maybe choose from. Simon Weston here describes the ethical eco leader as people that look across organizations, making connections, but who understand the really human elements of change. And I guess many of us might be happy to think of ourselves already in this way, and can even see how lean encourages this sort of flow of information and engagement across teams. But it might be a bit wider than that, I would think, being curious about where things come from, what they're made of, what happens to them after we finish with them, are all really interesting questions that we could add to our improvement work. Now, some leaders have already stepped up and put themselves in the spotlight. And here's Julian Hartley, previous chief exec from Leeds in England, who stood and made a public commitment to one of the largest groups of hospitals in the UK that they would reduce their carbon footprint and engage healthcare staff to make a difference. One of the greenest trusts in the NHS. They have a carbon literacy course. They've green ambassadors. Those ambassadors work to make differences in their own areas, and they're trying to embed environmental issues into all of their lean improvement work. And here's Minister Simon Cover from Tavula, making a really important and quite dramatic point to the COP in Glasgow. In his tiny South Pacific nation, the water is rising and their country is drowning. They have only 10,000, just over 10,000 people, and 1 in 3 of their citizens have already entered a ballot for a world first, I think, climate visa, which would allow those people to permanently migrate to Australia. So from 2025, there's a mobility pathway which has opened up so that about 300 Tavalians each year could go to Australia to live, work, or study. One of its first of its kind in the world, but this is then population migration due to climate change happening here in front of us. But you might see yourself as a slightly different sort of leader. This is an activist leader, one that walks towards the issue, one who might just ask those more difficult questions of the manufacturer, who might think about where something came from and start a movement, maybe in your own ward or in theatres or in a department. Of course, you're going to need the knowledge and you're going to need some friends to understand the issues, and maybe those will be new friends from estates or pharmacy. But together you'll have a mission to use the method we're familiar with to make a real change. You could take it head on, like Sophie here and her daughter Reed, a healthcare improvement specialist by day and a passionate activist at the weekends. Our trusted staff want to do something. Could using lean with a green perspective in this way let them? This isn't a technical movement. It's a social movement. Or you might be a little more active. Here's Juliet Brown. Juliet's a psychiatrist from East London and their sustainability lead. I'll just pause a moment to let you read in her words about their action. So Juliet was one of 6 health professionals on trial in 2024, accused of criminal damage to one of those London buildings of JP Morgan. You might remember the quote I just showed you about their CEO wanting to engage with those bringing issues to their door. Irony not lost. At the trial, the jury were unable to agree on a verdict, which means that Juliet and the others will face a retrial in 2026. Now, Juliet's described to me that an estimated 130 health professionals in the UK alone have been arrested for climate action in the last 5 years, with many more involved in other ways. So I'm not encouraging you to go and break windows, but maybe we really do need to think carefully and listen to what's important. So I was an eco leader, and maybe now I've become more of an activist. I feel really I'm a bit of both. As an eco activist, I want to learn more. I want to share what I've learned, and I'm not afraid now to say what I think maybe needs to happen to the people that can influence and can help. What has happened to me is I now feel really inspired and encouraged by the amazing young people that I've met who have hope for the future and are both innovative and creative. Now, by now, I think you probably know I'm asking this question. What if every improvement initiative considered the environmental impact? I'd like you to think about that. But what can you do now? I hope that you will use your voice, your position, to share some of what we now know, bust some of the myths, be an ambassador. I really do want healthcare to be part of the solution as well as having been part of the problem. As an eco-activist, a researcher, and still a passionate healthcare improver, I feel I have the responsibility of progressing our improvement science to link the design and delivery of healthcare to the health of our planet. I would love you to come and join me on this adventure. I'm going to give the last word to Greta, because in healthcare, we are scientists, and unfortunately, there is no planet B. Thank you very much.
Thank you so much, Elaine. We have a good number of folks who are able to stay with us throughout this presentation. So if anybody would like to come off mute and ask a question, but before we do that, we're going to do a virtual applause, which is always a little bit sad.
Very kind.
But while people are, I'll give people a moment to just think about a question. Elaine, we had a speaker from the Door School of Sustainability. You may have heard about that. That's the newest school at Stanford that started a year or two ago by John Doerr. And it's actually my next door neighbor, Tom Yaramillo, who gave the talk. And you know, we all think about things that we can do as individuals, but would you mind, are there a few things that you have observed in your studies that institutions are doing that are new and impactful and that, you know, we might be able to be aware of and get behind?
Yeah, sure.
Sure.
Yeah, that's a great place to start, Lisa. The hospitals in our healthcare system, we talk about systems, but hospitals are the biggest emitters, the biggest place where you can find things that you can change. So in the system, go into the hospitals. Within the hospitals, head for the operating theatres. Those are the places where we see the biggest emissions, lots of waste. It's not the only place, but it's a good place to start. And in my personal experience, anaesthetists are our friends. They are on this environmental journey. They have spent a long time looking at their own gases. They've had amazing changes in their practice around desflurane. They've managed to take that out in some countries. In Scotland and England, we no longer use that very, we now environmentally toxic gas because there are alternatives. So head for hospitals, head for theatres, find yourself a friendly anaesthetist, and then look at some of the things that people have found are working in other places. Nitric oxide would be, again, one of the things I'd get people to look at. We've historically had that piped around every hospital I've ever worked in. And most of it we now found is leaking out and disappearing into the atmosphere and is hardly ever used. So we've managed to influence a number of new build hospitals to not have nitrates, to actually go back to canisters if they need it. We're not saying don't use it, but actually don't have these huge big manifolds that are leaking out, costing us money and damaging the environment. Outside hospitals, practical things like inhalers also have an impact, asthma inhalers. So there's some great pieces of work that people are doing on changing the way that the sorts of inhalers and also recycling some of those. plastics. But some of the preventative things, I think, Lisa, almost are off the radar. We spend a lot of time thinking about physical waste, plastics, bags of stuff. All of that's good, and I really want us to think about that in our improvement work. But actually, did we need it in the first place is the thing we should be asking ourselves. Rather than worrying about how to get rid of something, when we've got it, did we need it? Because we have become quite used to having a lot of stuff around us, and the companies love us to have that stuff because they make more money from it. So I think looking at it with our improver's eyes, with green glasses, actually really does change the way people start to look at their whole systems. Actually targeting over treatment, over prescribing, and eliminating unnecessary procedures and practices. They're things as improvers we know, but they have an environmental benefit as well.
I'm looking in the chat or looking for a raised hand if there was anyone who wanted to ask a question from the audience. I have so many questions. So one of the things, Elaine, I don't know if you've heard of this. We had a speaker, Dr. Fran Gans-Lord, was speaking to us. She also spoke at our Lean conference a couple of years ago, and she was talking about health equity. And she had introduced at her health system, when they start their fishbone diagram, there's actually a prong on it that, just as you're beginning your problem solving process, to have a plank of health equity. And I wondered if you have seen that or you use that, just in your problem solving methodology, you have a sustainability plank that you incorporate.
Yeah, I think the answer is yes. You can include it in the fishbone. You can add it as an extra box onto your A3. You can look at it anywhere. And in fact, the problem is measuring. And Lisa, I go back a long way with Lean. And I remember when people used to say to me, you can't put a price on an ITU bed. You can't do that. Everyone's different. And that's true. We get that that's true. But quite quickly we found a common currency, didn't we? Where every time you did an improvement and you found an ITU bed, you had a price, whatever that price was. And so long as you used the same price for everybody in every project, that was okay. In environmental work, it's a bit more tricky. What on earth is a CO2 equivalent kilogram? At the moment we're not familiar with it. It's not language we understand. It doesn't make sense to us. So we've got to start to try and find a way that we can describe this in our improvement work so that people can go, all right, I saved a plastic cup and that's worth this amount of carbon. Does that matter? And because I saved it over 6 weeks, I can times it by 6. We need to simplify it and demystify it so people can actually see, as we did in dark and light green dollars, what's the impact of the improvement that we've made. And so I would encourage us to just start gently including it in the work that we're doing. There's been some success in looking back at projects actually that have already been done and saying, hey, okay, we started using, for example, video consults. How many journeys didn't happen? And then when you start putting the miles in, that starts to resonate, that starts to make sense for people. So I think we're just coming of age. It's quite a new area for healthcare to start even getting its head round. So a common language, a common currency, and include it wherever we can. In Leeds, every single improvement project has a dimension for the environment, everyone, which is fantastic.
I also wanted to ask, and I apologize if I missed it on one of the slides, but I saw when you saw like who are the biggest culprits in this contribution to global warming. I think the United States was like 27%, and then I think was China next. But who on the other side of that equation, um, what countries are exemplars that in your studies that we could learn from?
Yeah. You just need to step into Scandinavia, and almost every one of those countries is doing something amazing. So they are doing great stuff, but interesting. People often say to me, there's no point in doing this, Elaine, until China sorts itself out, what's the point in what we're doing? Actually, China, although they're a big emitter, they're doing extraordinary amount of work, much faster than many other countries. Now, we don't see an awful lot of it, and we hear about them building more coal-fired power stations, but actually they're not using them. They're not commissioning them. So that's what I meant about mist busting, really. It's sometimes that there's something that has been described as guilty knowledge. Once we know something, we can't unknow it. And that guilty knowledge, we don't quite know what to do with now. We feel guilty about it because, yeah, we know we need to do something, but what do we need to do? And the US health sector is actually just responsible for 8.5% of the national carbon emissions. So you're quite high in your national emissions in the health sector. The UK's around about 4 5. So best places to go, Scandinavia. They've been working on it for a long time. Places that you don't think were dreadful have a lot of coal, like Poland. So there's some places not to go to, and I've spoken in Poland and been surprised at what they were still doing. But we can always learn from somebody, Lisa. So, I spend my life looking for where is best, who does things the best. And some people, for example, Kathy Gerwig, who was working with Kaiser Permanente for a number of years, they managed to completely remove all of these toxic plastics and replace them with alternatives for their pediatrics. That's now law in Europe. But when I speak to companies, they say there's no pull for it. We're not being asked for these things. So as clinicians, we have a voice. If we don't know about it, we can't do anything about it. But once we know about it, we should put pressure on these providers to say, give us something different. I suppose I am inciting a little bit of a riot, but only a gentle one.
I'll ask just one more question because you had mentioned I was interested in what percentage of the and not that you would necessarily know this, but pharmaceutical manufacturers typically, the global, and so if that was an impactful area,
Yeah,
you would think
it's
we could if they made strides, we'd all make strides.
yeah, and I've been talking to people in GSK and AstraZeneca, and they are on the surface of it very keen to do something. There is actually in Scandinavia, not surprisingly, in Sweden, they have a green list of pharmaceuticals. So they've gone to the trouble to identify alternatives, but just as effective drugs that have less impact on the environment. And I'm just gently asking, why can't that be there for everybody? But of course, it's quite a lot of hassle for the pharmaceutical companies to change the chemistry, to start developing these things. If we ask, they will have to. Where they've asked in Scandinavia, they've done it. But for us here in the UK, now we're out of Europe, it's much more difficult to have a voice and influence. But I think a lot of my research is showing me that, like me, people just didn't know what they didn't know. When you're in front of a patient, Lisa, you just grab what you need to do the job, and that's right. But what we should be looking at is how can we procure the things so that when we grab them, we're confident they're the best things for the environment, as well as the best thing we can possibly use for the patient. None of this should compromise patient safety or care. sure people recognize that, but there are viable alternatives. We're so busy, we don't have time to find them. We need somebody to help us with that.
Elaine, you've been so amazingly generous with your time and getting close to 9 p.m. for you at home. So again, thank you so much for speaking with us today and this very important and thought-provoking topic. And I hope the next time that we speak with you that we have made some progress. And it's always, to me, it's just helpful to speak to someone from a sane country in this insane I live in right now. And I just hope, things have got to improve here. And we all on this call appreciate the importance of your bringing this topic to us and having us consider what actions we can take to improve the situation. So thank you. And thank you for everyone who joined the call today. We know it's a very, very busy week. And hope to see you in a couple of weeks. August 12th, Selena, is that correct? Is our next lecture? Thank you so much. Well, thank you, everyone, and have a wonderful rest of your day and have a wonderful evening, Elaine.
Thank you so much. Thank you for having me. Bye now.